Hello everyone, welcome to Noble Psychiatric Services presentation. I'm Dr. Ondieki and I'm one of the guys behind the Noble Psychiatry and the Noble Pathway. I'm excited to welcome you to this presentation. I want to begin with one question. What happens when mental health challenges go unnoticed, misunderstood, or untreated? Every day we encounter individuals silently struggling with depression, anxiety, trauma, suicidality, and other psychiatric conditions that not only affect their mental health, but their families, relationship, and the quality of life. This is why this conversation is important. Today, we'll explore Major Depressive Disorder, which is MDD, in a practical, evidence-based, and clinically relevant way aimed at improving patient care and strengthening our approach as mental health professionals. Thank you for being here, and we will get started. This presentation is produced and designed by the Noble Psychiatric Services. The purpose of this lecture is to deliver a thorough practical knowledge about major depressive disorder or MDD in order to put it in clinical practice. Learners will be introduced to the DSM-5 diagnostic scheme with emphasis of the fundamental symptomatology and the level of diagnostic threshold. We are going to overview subtypes and specifiers which determine the choice of treatment and prognosis. As far as the epidemiology, major depressive disorder is one of the most common mental health conditions across the world, and it is estimated that lifetime prevalence of the issue rests at about 16 to 20%. The onset happens at later stage of adolescence or early childhood, and it is almost twice in women than in men. Years lived with disability are another major cause of MDD, which makes the important contribution to the worldwide burden of the disease. On top of personal misery, it has significant social cost in form of loss of productivity, absenteeism, as well as healthcare usage. The danger of suicide in people having MDD justify the significance of timely identification and prolonged treatment. The DSM-5 diagnostic criteria, according to the DSM-5, MDD can be discussed as the existence of 5 or more symptoms at the same time period of 2 weeks, indicating a decline in prior functioning. Poor mood or lack of interest or pleasure should be included among those symptoms. The most frequent used one of the SIGCAP mnemonic: sleep, interest, guilt, energy, concentration, appetite, psychomotor changes, and suicidal thoughts. You should note that the symptoms above are characterized by substantial loss or discomfort, could not be traced to any particular substance or other medical conditions. And this is a very crucial point. The revision of the DSM-5 helps to exclude grief or stress symptoms in place of pathological depression. We'll look into the subtypes. MDD specifiers improve the diagnostic and the treatment by identifying clinically different presentations. The prediction of poor response to the treatment and increased risk of suicide is caused by anxiety distress. Mixed features are those showing subthreshold manic symptoms and here, in most cases, point to bipolar spectrum participation. Psychotic features, on the other side, need to be treated with combination of therapy involving antidepressants and antipsychotics. Specific atypical features pertain to the mood, reactivity, the hypersomnia, as well as the appetite, and frequently attributed to early onset and insidiousness. Seasonal pattern is in line with circadian and changes in the light exposure. Subtype of the peripartum onset is in the depressive symptoms process in the context of pregnancy or postpartum. The identification of specifiers enhances clinical management and outcome determination. When we look into differential diagnosis, a precise diagnosis of MDD must exclude the possibility of other or comorbid conditions. The exclusion of the bipolar spectrum should involve checking if a person has previously manic or hypomanic, since a wrong diagnosis can cause both an incorrect monotherapy of antidepressant leading to destabilization. Adjustment disorders are mood disorders after one can identify stress triggers but do not have a full inducement of MDD symptomatology or the length of stay. Depression may be in form of medical contributors, including endocrine disorders, vitamin B deficiency, or the chronic infections. When symptoms are experienced in an aftermath of intoxication or withdrawal, symptoms or withdrawals, substance induction of depression is to be considered. Proper evaluation can be facilitated by documentation of the collateral history and laboratory analysis to make sure that the treatment is directed towards the right underlying condition. As far as the neurobiology model of depression blamed the disruption of the monoamine neurotransmitters and their imbalance, such as serotonin, norepinephrine, and the dopamine, resulting in the disruption of the mood regulations. Hypothalamic pituitary adrenal HPA axis dysregulation is a causative factor of high cortisol and neuroinflammation associated with atrophy of the hippocampus. The neuroimaging results demonstrate that the prefrontal cortex connectivity with the limbic region, such as amygdala, is reduced, which causes emotional disturbances. The network dysfunction paradigm combines the finding with a focal point on the dysfunction circuit in the brain as opposed to the focus on single neurotransmitter deficit. The studies have helped development of pharmacological agents and the combination of biological and psychosocial therapy to facilitate recovery. As far as the psychosocial aspect of things and the cognitive models, biological explanation of the MDD are complemented with the psychological and social models. Cognitive triad in Beck's theory, according to which the cause of depression is the presence of negative, repetitive thoughts about the world, self, and the future. The theory of learned helplessness indicate that when stress has been constant and uncontrollable, hopelessness and passivity will be experienced. The impairment of attachment and interpersonal stressors are also considered to be contributing factors to the vulnerability, especially in case of people who do not have a constant social support. The negative childhood experience, ASACE, and the traumatic experience increase the risk through this desensitizing stress response system and maladaptive coping. By identifying these stressing factors, clinicians will be better able to modify psychotherapy to involve restructuring the maladaptive cognition and enhance interpersonal resilience. As far as the initial assessment and risk evaluation, primary examination is to be done by comprehensive psychiatric interview of the previous symptoms, chronology, triggers, and functional effect. The PHQ-9, Hamilton Depression Scale, Montgomery, Asperger's Depression Rating Scales are standardized instruments that improve the accuracy of diagnosis and assess the progress. Suicide risk assessment is necessary, the essential distinction between passive and active thoughts and plan. Comorbidities, conditions, medication, and substance use should be checked to determine the contributing or mimicking factors. While it can be, when it comes to the laboratory work, the thyroid function and the level of vitamins can be included. Integration evaluations help towards biopsychosocial formulation of the treatment in an individualized manner. When we look at the treatment overview, the treatment of MDD is step-based care, which is in line with the severity of the symptoms. In mild cases, initial therapy is structured psychotherapy in CBT or cognitive behavioral therapy or interpersonal therapy or IPT. The combination of psychotherapy and psychopharmacotherapy and psychotherapy is typically the appropriate choice to treat moderate to severe depression. The lifestyle changes such as sufficient sleep, physical activity, and social interaction are also supportive pillars responsible for enhancing resilience and avoiding a relapse. Clinical decisions are based on patients' preference, earlier responses to treatment, and comorbidities. Follow-up is used to make sure compliance is achieved and early signs or side effects or indicators of relapse are also detected. As far as the antidepressant psychopharmacotherapy, the treatment of the moderate to severe MDD is based on antidepressant treatment. The first-line choice is selective serotonin reuptake inhibitors, SSRIs, or serotonin norepinephrine reuptake inhibitors, SNRIs, because they are effective and tolerable. Other options like bupropion are stimulating and can be applied to fatigue or sexual side effects, whereas something like mirtazapine works with patients affected by insomnia or lack of appetite. Clinicians ought to establish optimism of gradual improvement within a period of 4 to 6 weeks and watch out against side effects or suicidality. symptom clustered based on comorbidities, based personalized selections with concurrent enhancement of personally tailored responses leads to improvement in adherence in outcomes. Ineffective response can be followed by combination or augmentation strategies. Psychotherapy modalities. Psychotherapy has continued to form the backbone of treatment of depression. CBT focuses on detection of inaccurate thoughts pattern and reward that avoidance behaviors are used. Interpersonal therapy, IPT, aims at addressing conflict, role changes, lack of social support, which determines a worsening of depression. Psychodynamic approaches examine conflict and past relational experiences that define the present prevailing effective reactions. Integrating medicine with psychotherapy usually bears more success than each of the two modalities, specifically recurrent or chronic depression. Modality should be chosen according to the preference of the patient, the history of their treatment, and the experience of therapists. Treatment-resistant depression. Treatment-resistant depression, or TRD, is said to be inappropriate response of two or more sufficient trials belonging to different antidepressant groups. The management is initiated by checking the compliance, dosage, sufficiency, and diagnosis. The augmentation intervention can be lithium, T3, or typical antidepressants like aripiprazole is something that we tend to use quite a bit. In case of a failure, interventional models including ECT, electroconvulsive therapy, or repetitive transcranial magnetic stimulation, RTMS, can be regarded as effective evidence-based on suitability. The refractory cases could be treated with the help of newer therapies such as esketamine nasal spray or the vagus nerve stimulation. Individuals' multidisciplinary approaches are significant to functional rehabilitation and suicide prevention. As far as the prognosis and long-term management, MDD typically has recurrent, progressive, and risk of relapse is great within 6 months of remission. The recurrent rate can be significantly lowered by maintenance, treatment, prolonging antidepressant or psychotherapy after the symptoms have been overcome. Psychoeducation would assist patients to realize the warning signs and code of treatment adherence plans. Resilience can be achieved by addressing sleep, hygiene, physical exercise, social bonding, as well as prevent relapse. Timely intervention can be achieved by timely follow-up in case the symptoms reoccur. The goal is chronic management should be geared towards remission as well as rebuilding psychosocial function and quality of life. So as far as the key takeaways, MDD manifests in heterogeneous etiologies and manifestation, and in order to achieve optimal outcomes, the application of biopsychosocial method is necessary. The DSM-5 based diagnosis lead to precise diagnosis and subsequent treatment that best fits the needs of the patient. There are reasons to believe that the pharmacological, psychotherapeutic, and lifestyle intervention should be integrated as opposed to treating the problem exclusively with one therapy. Clinicians are to be watchful to relapse, comorbidities, conditions, and developing psychosocial stressors. Care models involve collaborating with models that enhance the continuity and adherence. It is hoped that this discussion will support the foundation knowledge and promote reflective clinical practice based on empathy, evidence, and patient care values. And that concludes this presentation. Hopefully you are able to learn something about MDD and you will be able to use it in your future practice. With that, from Noble Psychiatric Services, I want to thank you for listening. Thank you for taking time to come to listen to this presentation. We wish you the best and we will look forward to seeing you on the next one.